Hello and welcome everyone to tonight's webinar on lifestyle and non-hormonal interventions in the perimenopause period. This webinar is brought to you by Capital Health Network and medical and allied health menopause experts in the ACT. This webinar complements a previous webinar on hormonal options for the menopause, which can be found on the Capital Health Network YouTube page. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. I am Dr. Leonie Harcourt, a GP Education Advisor at the Capital Health Network. Also with me tonight is Kunal Mohiti, the Events Lead at Capital Health Network, and of course our wonderful speakers, Dr. Virginia French, a GP and Australian Menopause Society qualified doctor, Hilary Sargeant, a clinical psychologist with a special interest in the menopause, and Kate Freeman, a registered nutritionist who offers help and advice to women to enhance their physical health around the menopause and beyond. All participants have been muted, so if you have any questions, please type them into the Q&A section and not the chat box on your Zoom window. So type into the Q&A section, not the chat box. We'll have a question and answer session after all the speakers have presented. And the presentation itself, we uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. Regarding CPD, please fill in the post-event evaluation. CHN will email you a certificate of attendance after the event. That might be in about 2 weeks, so not immediately. Please feel free to self-report 1.5 hours of educational activities to your CPD home. And also just a shout out for Health Pathways. As you may know, Health Pathways provides free guidelines and advice on the investigation and treatment, including localized referral options of many conditions, including the menopause. And just the refresher, the login is together, the word, and the password is for health, FORHEALTH. So all lowercase together, and for health, all lowercase. And so on to our wonderful presenters. So I'll introduce all of them together because they're going to tag in and out throughout the evening rather than talking in blocks. So our first speaker, in no particular order, is Dr. Virginia French. Virginia qualified in medicine from Sydney Uni and spent many years training and working in the UK. She has a background in obstetrics and gynecology, forensic medicine, specialising sexual offences, primary care, and clinical governance. She specialised in menopause care since 2018 and has presented at national conferences on the impact and management of menopause transition symptoms. Virginia opened her own women's health clinic in 2022. Our second speaker tonight is Hilary Sargeant. Hilary is a clinical psychologist with nearly 20 years' experience. She has a special interest in women's health across the lifespan, including coping with issues related to endometriosis, painful sex, infertility, the perinatal period, and menopause. Hilary worked for many years in psycho-oncology with the Cancer Council of Queensland and has been working in Canberra in private practice for the last 8 years. And our third speaker is Kate Freeman. Kate is the founder of the Healthy Eating Clinic, a nutrition and dietetics practice. She's a registered nutritionist with the Nutrition Society of Australia and has over 18 years' experience in the field of nutrition. Kate has a Bachelor of Science in Nutrition from the University of Canberra and a Master of Nutrition from Deakin University. She's currently the Registered Nutritionist Ambassador for the Nutrition Society of Australia and serves as a member of their Registration Advisory Board. More recently, Kate founded Ayla Health, a mobile application that provides nutrition education and supports industry. The app teaches people how to eat well for the rest of their lives through incremental habit building and meal organisation. So we've got some very, very well qualified speakers tonight. I will stop speaking now and hand over to them. Thank you.
Hi. So if I should just share my screen now, we can get started. This one. Present. Lovely. All in order. Well, thank you very much for having me. We are talking more about the non-hormonal management of perimenopausal, menopausal symptoms. And as Leonie has said, we've got a number of speakers tonight to help diversify the information presented to you. We are going to cover a number of topics. We're going to start with mood and cognition, move on to somatic symptoms, weight gain and nutrition, sexual and urogenital symptoms, vasomotor symptoms, and then the positive outcome once menopause transition has been achieved. So as stated, I have my own clinic and I actually do aesthetics as well. And that is a really important pairing for midlife transition women, particularly in Canberra, when we have a lot of educated, highly professional women who are struck by the cognitive and mood symptoms, particularly of perimenopause, and it severely affects their career. And so managing appearance whilst coping with the impact on other aspects of life can be incredibly important when people are confronted with the sudden changes that happen at this time. It is important to remember that not everybody and not every woman is going to experience symptoms of the menopause that are significant enough to require treatment. And about a quarter of women really won't notice very much significant at all. 20 to 25% will have severe symptoms, and the rest of women will have a range of symptoms which may or may not become troublesome enough for them to seek advice. It's also really important to recognize that the symptoms can be incredibly varied. I'm not going to play this video now. If you have time at the end, I will. It's just a humorous snapshot of the variety of symptoms and the impact that they have on women. And it's an opportunity for us to highlight how important it is for us as GPs to hear what women are saying, understand what their experience of their symptoms are, and to embrace that even if you don't know how to fix it. Because a lot of women need validation that their symptoms are real, that they are experiencing them, and they'd rather have that acknowledged and say, I don't actually know how to help you with this, than to deny the symptoms exist because you don't know how to perhaps direct a management option for them. And it might also surprise you because a lot of the talk I know about menopause is about the impact of flushing and typical symptoms that happen later. But when we're looking at the impact, it's actually the perimenopausal impact symptoms that have the major changes to how women cope, because these are the things that affect their participation in the workforce. So in actual fact, the biggest impact is sleep disruption, the fatigue, impaired concentration, and poor memory. And there are incredibly good, reliable research works that demonstrate the cognitive impairment that happens around this time. And women can lose 30% of their cognitive function. They can lose an awful lot of energy through impaired mitochondrial function. We know that their memory and recall is impaired, their spatial analysis is affected. So it is a genuine biological problem that estrogen deficiency is affecting function, which affects a woman's ability to manage, and that affects her ability to participate in work. And so our role is to identify when she's struggling with these symptoms and support so that treatment can be implemented and decisions about participation in work are made in a measured and not a reactive and life-damaging way. So when we're thinking about perimenopause, we're thinking about mood and cognition symptoms. These come first. And they can come incredibly early. You may have had patients who've come in their late 30s wondering if they're perimenopausal. Don't dismiss it, because we know that 1% of women will actually go through menopause before the age of 40. And certainly by early 40s, you can see some pretty significant perimenopausal changes happening. That doesn't mean they necessarily need treating. A lot of women are curious. They're wondering what's happening. They're recognizing these changes, and they want to know, is this a real thing? And explaining the neurobiology of what is happening to her brain is incredibly important. So the value is in allowing a woman to know her own body and allowing her to come to you and say something is different. I'm experiencing these things, and don't dismiss it or disregard it or attribute it to a previous diagnosis of anxiety, depression, or stress. Quiz women on other symptoms that are going with it so that you can explore where she might be in her perimenopausal journey, and that she might then be able to be on the lookout for symptoms that might increase her burden or her progression through this so that she can understand where she's at and what treatments might be available. And it's an incredibly individual journey. And I really would encourage people, because these symptoms are estrogen deficient symptoms, if you're not happy talking about hormone replacement as an option, then you should be referring to somebody who does. So even when you're discussing non-hormonal management of perimenopausal and menopausal symptoms, one of the things you should be considering is, would somebody like to try hormones? And if they do, allowing them to access that service if you're not comfortable doing it yourself, and also exploring the non-hormonal options as appropriate. And I thank Claire Holberton and Tara Frommer for the talk that they gave some months ago about menopause hormone therapy and management. So if I've got a woman and I'm not quite sure if she's perimenopausal or not, I ask a few questions, and you can very easily go top to toe, because estrogen deficiency affects every tissue of our body. You can basically pick a tissue and see if there's any symptoms related to it, but I tend to start from the top down. So I ask about headache and migraine frequency. Fluctuations in hormones tend to increase migraines. Mood symptoms are incredibly common. Are they feeling more irritable? Are people reporting on their irritability? Are they angry at themselves for the way they're behaving? Has something changed about their anxiety? So people could have a long history of anxiety, but it changes around a perimenopause. People will report that they're worried about things that they previously didn't worry about. They've got insight that they shouldn't worry about these things, but they do anyway. They're ruminating about things like serious worries about things happening to their family, which is out of context, and they can rationalize it doesn't make sense, but they feel it anyway. They might not be able to do activities they used to be able to do, and routine things like taking kids to football practice can become really problematic for women when it wasn't before. So changes in anxiety, really important. Fatigue, and it's the bone-tired fatigue of just dragging yourself through the day and not being able to do any activities outside of work, really not having any capacity to do anything more than the absolute essentials, and it be dragging deep and not replenished by sleep. Concentration is impaired, so people's executive function is impaired. They're less efficient at work. They're spending more time achieving less. They're forgetful with their tasks. They forget important things for family. They can't organize their time well. ADHD starts being shown up for people who've had coping strategies for many years. ADHD in the midlife can become more problematic because you don't have the energy and the dopamine reward of goal setting and achieving, and you've got fatigue. So you've got lots of open tasks at the same time. You don't have the energy or the executive function and concentration to get them done, and you end up in a cycle of failure. So that's when that becomes apparent. Dizziness is an incredibly common symptom. You get hair problems, dry eyes, dental problems for the first time for a lot of women, rosacea, skin changes. You get an expansion of premenstrual symptoms, thinking more of the mood symptoms, taking up more of the cycle, having a bigger effect, affecting relationships. Breast tenderness is very common as you get those high fluxing estrogen flows with the premenstrual phase. You get sort of recurrence of breast tenderness that might not have been there for years, or increased breast tenderness. Tummy upset, increased food sensitivities, changes, diarrhea, constipation, bloating, body aches, feeling warmer even if they don't feel like they're having flushes or sweats. You can ask, do you actually just run warmer than you used to? And changes in the features of the menstrual bleed. So even though a woman might have continued regular cycles, she might be having flooding bleeding in the first couple of days, particularly with clots that weren't there before, or might have spotting that happens before and then after the period, which is new for her. And so the big part of this is this high flux estrogen surge that happens in this perimenopausal phase, the early phases, that triggers brain remodeling that is as significant as what happens in adolescent time. And this, one of the big changes that happens is, even though you've got high estrogen levels, you actually have the effects of estrogen deficiency because of the fluctuations. So the anxiety center, the amygdala, gets actually bigger, and the control centers for that shrink. So you've got a more reactive brain with less capacity to moderate those reactions. Prefrontal cortex shrinks. You get loss of gray matter and loss of white matter. It affects your hippocampus, so you can't recall things. Your memory's impaired. Cognition and learning is impaired. There are very, very strong relationships between estrogen and serotonin levels, dopamine and glutamate, which affects mood and cognition. And you can measure the deficits in cognitive function You can replace estrogen and see them return. So this is neurobiological basis, and women are much more comfortable with what they're experiencing when they know that it is a biological process and it's not some fault of theirs that they're having trouble with these symptoms. The cerebellum is affected, so people become clumsy, similar to premenstrual phase when people sort of lose some of their coordination. The day-night center and the sleep center is affected, so this creates this nighttime waking where patients are wide awake in the middle of the night, unable to get to sleep no matter how hard they try. So they're absolutely bone dog tired, but then can't sleep. So it's torture at both ends for people. And of course, you can't know for sure whether a person is in perimenopause or not. We don't have any tests for it. You're essentially looking at someone's cluster of symptoms, the way they feel, the way they report, their age, and you come to the conclusion. And I know that this isn't about menopause hormone therapy, but you can trial it and see if it works. And for many women, it will. It's a very low risk treatment now, particularly if you're still in your 40s. And you could certainly trial it and see if it improves the woman's well-being. Regardless of that, just acknowledging that that might be where the woman is incredibly helpful for her. And what we don't want to see too much of is rushing towards using antidepressants as the first line treatment. So as soon as a GP hears anxiety, depression, and a person's in their mid-40s, they should be questioning, is this perimenopause? I undo a lot of antidepressant prescribing, and a lot of women walk away with the prescription and then say, I never took it. It just wasn't what I wanted. It wasn't right for me. I knew it wasn't the solution. I knew that wasn't the problem. I wasn't depressed, although the symptoms can sound a lot like depression. And a couple of the key phrases that you hear is, I just don't feel like myself. And I used to manage stress better. Yes, midlife is an incredibly stressful time, but women can reflect that they feel like they should be able to handle it better, but they're not coping. And feeling like you can't cope with a situation, not understanding it, and not having a plan of management or a sense that it's going to end is incredibly catastrophic for people. It really creates panic and fear. And that's where our role for education and support can really be of value. Some women will come back and say, some to me and say that they're absolutely terrified about what is happening to them because they've got a career that they're running. They rely on their cognitive function and energy to do their job. And without that, their world comes crashing down. So it's an incredibly scary phase for people. Again, another tool if you're feeling unsure about the perimenopausal phase is the Australasian Menopause Society's question. This is the modified green scale, a little old-fashioned, but if you need a checklist, it can be really helpful to prompt you. If you are choosing antidepressants or you have a patient who doesn't want or doesn't need or isn't eligible for menopausal hormone therapy, then there's a pattern of antidepressants that seem to be more beneficial in this stage. And they are desvenlafaxine, which actually has the best evidence base, escitalopram, vortioxetine, and agomelatine. Just a reminder that with paroxetine and fluoxetine, they do affect the metabolism of tamoxifen, so please don't use them in a breast cancer patient who's on tamoxifen. And interestingly, about 2 years after the menopause, mood symptoms tend to settle and the rates of depression are actually the same as they are for males. And there is some work that shows that instituting menopause hormone therapy from a couple of years after menopause transition is complete is actually ineffective. And so managing that as you would with depression and anxiety without hormones is the most appropriate. And so many women have tried complementary therapies and herbs before they come to me. Unfortunately, the evidence base hasn't reached a threshold to which any of the menopause societies would recommend particular herbs or supplements. They certainly appear to be safe and women might get some benefit from them. Very, very welcome to try it. I don't necessarily recommend them because by the time they are seeing me, they have symptoms really that justify more definitive management. If I were going to pick one, if it were for hot flushes, I'd choose black cohosh and evening primrose all together. That's got the best evidence. And for mood symptoms, people often go to chaste treeberry or Vitis agnus castus. But again, the evidence isn't terribly strong, but helpful. If it helps and the woman feels better, happy days. There are some randomized controlled trials with these medicines, but unfortunately, the sample sizes are all too small for them to reach particular value for evidence-based medicine. And before we hand over to Hilary, I just wanted to talk about the effect that the transitions and changes that a woman is experiencing has on her partners. I'm going to talk about male partners, but I mean female partners as well. When your estrogen levels drop, the previous motivation to care for other people first and to be quite compliant actually reduces. So hormones and estrogen do make women more motivated to care for others, community sense, external first. But as those levels drop, the center of care actually comes to work towards the woman, and some resentment sets in. But what we have is a decade or two of behaviors that have been set both by their own motivations and societal influences and the responsibilities of caring for other people have set up patterns of behaviors that then can create resentment, because if she's feeling incredibly tired, very irritable, not really feeling she can give to other people because her own needs are not being met, but those demands continue, then you can see a lot of resentment, and then you see a lot of guilt because a woman still cares about the people in her life, but is struggling to meet the expectations that she and maybe other people have of what she should be doing. This can affect partners, particularly males, because they don't necessarily understand what is happening, particularly if the woman herself doesn't know. Their ground is shifting constantly. So there's been a pattern set up within that family unit for a decade or two, but now the rules are changing and it's really unpredictable from day to day. We talked about the irritability of mood that women experience, the sudden anxiety and outbursts that they can't control. That can be then experienced by the people around her. And it's unsettling, particularly for men who can't quite predict what they should be doing. They don't know what's expected of them. They don't often know how to help. They can feel a sense of uncertainty in their role. They can feel isolated because if the woman's libido is changing, which often does, and there's less sexual contact, then their intimacy is affected, and that can affect a man's confidence about what their role is within the relationship. And there can be some financial burdens because, as we spoke about, women will often need to reduce their workload or withdraw from work and change their financial rewards from work. And that can place burdens on partners in order to fill the gap. And so on that note, I introduce Hilary, who I think is going to talk a little bit more about these topics.
Thanks very much, Virginia, as I wrestle with the technology here. All right, I think we're okay. Thank you so much for having me talk to you tonight. It's very weird knowing that there's a bunch of you out there and I can't see any of you, but I hope that you're enjoying the evening so far, and thanks for allowing me to speak. I really like working with this client group. I find it very rewarding, and I think often because women have put themselves at the bottom of the pile for so long at this age group, and they have often delayed seeking help for quite a long time. And I guess sometimes that's because they are very busy and trying to juggle everything. And sometimes it's the stigma still of seeking psychological help. So I think anything we can do to normalize seeking psychological support at any age and any stage is helpful, but particularly at this stage with these women who are very deserving and often very needing of this type of support. So I guess following on a little bit from what Virginia was talking about, the biological changes that she was describing that happen in menopause really do occur sort of within the context of varied lifestyles, social circumstances, and then broader social and cultural lives. So if the whole system is stretched, then any of those extra demands of some of those physical adjustments can really often feel like too much. But the good thing is that we know, I guess, that some of psychological factors such as stress can really play a part in the experience of those symptoms. And so if women can learn that it's not that what they're going through is not just down to hormones alone, that being able to focus on other factors that potentially can be changed can often, I guess, increase that ability to cope or that self-efficacy. So we're going to talk a little bit more about that today. So when we look at some of the common psychological issues that might arise, Virginia has touched on some of these already, looking at mood swings, depression and anxiety, certainly sleep disturbance and sexual difficulties. Looking, I guess, beyond that to some of those sort of broader system difficulties that people might experience, major life stresses that are related to that, that time in their life, caregiving, sometimes still for young children or sometimes for teenage children and elderly parents, experiencing career changes or relationship changes, as we were also just talking about. Body changes and body image can be an issue for people. Sometimes they've been long-standing problems. Other times it might be, again, in response to a changing body or changing function. Illness, that brain fog, the changes in cognitive function that Virginia mentioned, existential concerns in this society where youth is very much valued. What does it mean to people to be aging? Workplace problems are often a huge difficulty for people. And that sense of not feeling like myself. So some research, recent research looked at that sense of not feeling like myself and found that it was about 63% of women felt like that half of the time or more. And not feeling like myself is not a clinical sort of problem, but again, it was associated with anxiety, fatigue or pain, brain fog, sexual symptoms and volatile mood symptoms. So I guess that's a good one to listen out for as just a bit of a marker that perhaps there's some more things going on there. So what do we do as far as psychology? I guess we, the main evidence-based treatment for, in terms of psychological therapy is cognitive behavior therapy. So I'm going to just talk very briefly on what that might look like. Sort of slotting in with that into the behavior part is lifestyle changes. Large part of what we often do is also referring on for medication. So sometimes it's reviewing or looking at MHT. Sometimes it is antidepressants if that's clinically necessary. So cognitive behavior therapy or CBT, I guess, is really based on the idea of how we think affects how we feel and what we do. So we know that challenging or changing unhelpful thoughts can help with coping. So in this context, looking at, say, menopausal symptoms, it won't take the symptoms away, but thinking about them or responding to them differently can help. I suppose some of the things that I often talk to clients about, just a really simple model of, first of all, what's going through my mind just now, identifying those thoughts, and then asking, is it helpful for me to think like this? The new thoughts that we try and encourage people to develop don't have to be positive per se, but instead we look at helpful thoughts. Sometimes trying to change people's perspective might be asking questions of themselves, such as, what advice would you give a friend? Or what would a caring friend say to you? What evidence do you have for or against this thought? What's the worst that could happen in this situation? Could you cope with that? And what's the most likely thing that will happen? So I guess this is a very small nutshell this is sort of cognitive behavior therapy. If we look at it, I guess, a bit more specifically with hot flashes, for example. So here we've got on the left, the physical symptoms, going through a hot flash, feeling hot, sweating, palpitations. The thoughts might be something along the lines of, oh no, here we go again. Everyone's looking at me. I can't cope. This is never going to end. Out of that, feeling anxious, embarrassed, out of control. And so then that might affect the behavior. I might not go to particular situations where I think that might happen, or I might leave the room the instant that happens. And then likely I'm feeling pretty awful. Because I'm feeling awful, that's going to increase my stress. That increase in stress is more likely to have me experience a hot flash, and then it starts again. So there's, I guess, this vicious cycle between a lot of psychological experiences, hot flashes, sleep, stress, mood, and that's where trying to do something to intervene, I guess, in that cycle gives people a little bit more a sense of, I've got something I can do here. So if we have a look at the example on the right, same physical symptom, hot flash, thoughts instead might be, this will pass soon. Let's see how I can deal with this one. Now the feelings that result, I'm feeling calmer, more accepting, more relaxed. Behavior might be just breathe through the flash until it passes. So this is a really basic example, I guess. But we do know that, again, by feeling like you are able to accept what's happening, work through it, have some coping strategies in that moment, not feel completely afraid by what's happening. These are the sorts of things that will help people's experience of the hot flash or other menopausal symptoms. So I've had sometimes doctors ask me, well, how does the CBT work? And this is pretty much it. It's not about changing the symptom, but rather changing the response to the symptom and increasing the ability to cope and acceptance as well of what's happening. When we look at, I guess, that idea of reducing stress in this context, it is really important. We know, or there's research to suggest that everybody has this thermoneutral zone, which is the range of temperatures where core body temperature changes without having to actively regulate itself. So it just trundles along, not too hot, not too cold. Women who have hot flashes have a narrowed thermoneutral zone compared to other women who don't have hot flashes, but stress can also narrow that thermoneutral zone. So I guess this idea of improving well-being and reducing stress is probably good just generally for managing psychological well-being, but also can impact on the experience of those vasomotor symptoms. So the sorts of things that we might do with clients would be teaching relaxation breathing, helping people with pacing and slowing down, not trying to fit in so much, scheduling in meaningful activities into each day, engaging in regular movement and physical activity, and problem solving. Perhaps there's actually rather than just coping with something, there might be a practical solution to be had. So we've got structured problem solving strategies that we can talk through with people. Other sorts of things that we might do, working with sleep, I've got some slides on that in a bit. Behavioural activation we use more with managing depression, so making sure that people plan their day, including pleasant events, including relaxation, physical activity, but sort of having it scheduled in. Using social support. In the past, historically, people have kept their menopause experience very much to themselves, whereas we know, and I've had clients who once they've opened up to friends about their experience, then the friends will also say, oh yeah, that's happened to me. And that just that social support and that shared experience of that suffering can be extremely helpful in not feeling like they're the only one going through that. Often we're helping people with relaxation, meditation and mindfulness, sometimes talking through reducing alcohol or other substances and managing diet, which Kate's going to talk to us more about. So as far as screening for depression and anxiety, often, in GP visits, you've got very short time, but these questions are very effective screeners without even having to do much else. So really just asking during the past month or even during the last couple of weeks, have you often felt down, depressed or hopeless? Or have you had little interest or pleasure in doing things? If they answer yes to one of those, chances are pretty high that they probably are experiencing depression. And then for anxiety, during the past month, have you felt excessively worried or concerned? So just to touch on a little bit about depression and anxiety, recent research does suggest that women in perimenopause are significantly more at risk of depression than those in pre or post-menopause. But having said that, a first episode of depression is unlikely to occur as a result of menopause. Usually there's a prior history of depression and often that's hormonally related. So many of my clients have had postnatal depression or premenstrual dysphoric disorder, those sorts of experiences. A higher number of troubling symptoms, especially disturbed sleep and the hot flashes, is a risk factor. So there's that vicious cycle again between those various factors. So again, what we do for depression, generally CBT, perhaps behaviour therapy or mindfulness-based cognitive therapy. Physical activity is probably my number one, trying to get people moving. Again, that activity scheduling, relaxation, medical therapy, so sending them back to you guys. And again, like Virginia said, I also wouldn't jump straight into antidepressants unless a client, I felt that they were in significant risk of harming themselves, and that's a whole nother webinar. But certainly I'd sort of treat it a little bit experimentally. Let's see how we go just with psychological treatment, then go back to your GP, talk about potentially MHT or antidepressants, but have that conversation. So when we're looking at anxiety, sometimes we are looking at a recurrence or an experience of an anxiety disorder. But I think more commonly, I certainly just encounter this more generalized anxiety, particularly trouble with overthinking or rumination. Sometimes trouble coping with uncertainty or indecisiveness is another sort of common experience, problem that I notice. So part of managing anxiety, again, sort of building on the strategies that I've already talked about. Often learning more about anxiety, just doing that psychoeducation is very effective. Learning to manage your thinking differently. Those behavioural strategies such as relaxation or meditation, physical activity again. And then once again, if none of that's really seeming to make a significant difference, sending them back to their GP to have a discussion about whether medication's required. Again, I feel like, as Virginia said, more commonly the MHT makes a bigger difference with these types of clients. All right, so sleep obviously is a very common problem. The problem can occur anytime during the night, so trouble getting to sleep, waking up very early or waking through the night. Again, clearly hormones and the vasomotor symptoms play a role, but so do many other factors. So a history of insomnia, other chronic health conditions or pain, and other lifestyle factors. So these are the sorts of things, again, that we might be able to work with to help people manage. So CBT for sleep, what we're really looking at, I guess, is commonly decatastrophizing that sense of, oh no, I can't get to sleep. I won't be able to work. I'll never be able to function. What time am I going to get to sleep? And all of those thoughts that can sort of run on, helping people develop a more helpful response. Well, I might be awake, but I'm lying here in bed. I'm comfortable. It's warm. I can practice my breathing. So again, having some more helpful thinking to replace that really unhelpful thinking that tends to keep them awake. There's a lot of behavioural aspects that can be worked on for managing sleep. These, again, are a bit more general as far as, for example, having regular schedules, looking at sleep hygiene, making sure you're not looking at screens before bed. Some of the behavioural things that people might not necessarily do is looking at what their beddings are made of or what the temperature is in their room. Having a bit of a routine or a ritual for if they do experience sweats at night, what can they do to kind of, again, wind down ready for bed? So it might be that cooling off, going back to bed, practicing some relaxation breathing. Again, sometimes medication's required, and we send them back for experimenting again with some of those things. So I'm not going to speak too much about sexual difficulties except to say that they are very common. Again, can be anything from sort of interest to arousal. Vaginal dryness can be a significant problem. I'm sure Virginia will cover this in a little while. But once again, hormones are only one factor, and often there's other lifestyle and psychological factors that can play a part. Difficulty in the relationship, perhaps the partner's experiencing some sexual function. There might be side effects of medications. Body image might be at play. Teenagers in the house up late, might be cramping the parents' style, or sometimes some of those experiences of loss. So children leaving home, having elderly parents that you're worried about, or losing parents can all play a part in having these sort of difficulties with interest. Sometimes sexual issues can be long-standing. And so again, if people have had a difficulty in the past, they're much more likely to experience difficulties at midlife. But sexual difficulties might not be distressing for everyone. And some people feel a sense of liberation that that's not really part of their life, but they still have a very happy relationship. I guess that idea of sexual interest, it is highly variable between women. Research sort of suggests that overall sexual satisfaction in this area sort of remains the same because people do tend to make adjustments in response to their circumstances. But sometimes it can be quite distressing for people. So again, a few of the things that we might work on, helping them with some practical interventions, or sending them back to their GP to discuss those a bit further, lubricants, vaginal moisturizers, vaginal estrogen. Very commonly, I'm linking people back in with women's health physios if they're not already linked in. Sometimes we do talk about non-intercourse focused sexual activity, or I guess depending on what the problem might be, we might even do some more sort of, I guess, historical sex therapy like sensate focus. But again, helping them with some of those other lifestyle factors, exercise, relaxation, that can improve sexual interest. But certainly expectations, beliefs, and communication all play a part. And that's probably true for all of these things. If you think that menopause is going to be terrible, all of these terrible things are going to happen to you or are happening to you, then the way you think is very much going to affect how you feel and what you do. So if we can help people develop a helpful sort of mindset, then all of these things are going to be much easier. So this is a set of, I guess, information more for patients. But if you haven't encountered any of these things, then they're well worth a look at. I guess the couple of things that I would really point out The Balance app by News and Health is an app that I'm often recommending to people, especially in early menopause. You can track a bunch of symptoms and you can tailor it to yourself. You can track your cycle, you can track your mood, eating. There's a whole bunch of really helpful information. It's free, which is great. And you can also download a report for your GP. So that's something that's really helpful to recommend to people. As far as that idea of, I guess, normalizing menopause, I loved the Truth About Menopause show with Miff Warhurst. Many of these women would have grown up with Miff Warhurst as a contemporary, so she was the perfect one to present that. And as far as, I guess, some self-help or some bibliotherapy, the first book mentioned there, Living Well Through the Menopause. That's a book that's written by 2 clinical psychologists from the UK. It is an excellent book. It's people can work through it sort of themselves. And if people did that, I would certainly be out of a job. But it's something, if people are a bit unsure about seeing a psychologist, or if they want to find out a bit more about what they might do, that could be something that you could recommend, or certainly that they could do that in conjunction with seeing a psychologist. Not all psychologists know a lot about menopause. Our workforce seems to be, well, I'm getting older and older, but they seem to be getting younger and younger. We do know that a stronger therapeutic alliance is predictive of better outcomes, that the therapeutic alliance is responsible for significantly more of the variance in outcomes compared to the treatment modality. So knowing what you're talking about, particularly with this group of women, is really helpful and really important. Having said that, sometimes psychs might be a bit less experienced, and so a book like that might be something that they could take to their psychologist if they're finding that they like them generally, but they're not too sure. So that might be something that you can add on to what you do already. And I think that's it. Thank you very much.
Thank you. That's great. So Virginia, are you speaking now?
Yes, I'll carry on
Yep.
if it's okay. Okay. So thank you, Hilary. That's amazing. It just actually reminded me about a few things, and that was about the association between premenstrual symptoms, the crossover between that and premenstrual dysphoric disorder and perimenopausal symptoms, and the relationship between PMS and postnatal depression and mood symptoms around the perimenopausal transition. They're very good predictors of that. And I also just wanted to sort of highlight that the 3 components that the estrogen is very well associated with in terms of regulation are serotonin, dopamine, and glutamate, and just how important they are for mood regulation, motivation and reward, and learning. And then the recent work that's been done between glutamate and GABA and anxiety and how that all interplays. So I think it's going to be fascinating to see how the neurobiology is affecting our interpretation of symptoms as time goes on. So a quick chat about somatic symptoms. I appreciate time's moving, so I'm going to go quickly. Perimenopausal menorrhagia, we talked a bit about periods changing being a characteristic in perimenopause. I just wanted to highlight that if you're going to use a contraceptive pill for this group of people, Zoli is a very good option because it's got a body identical estrogen in it. It is very easily transferred over to HRT doses because we know how to convert that. And it has a synthetic progestogen still in it, so it's better at controlling periods than Prometrium is. If you are going to go for a progesterone-only method just to remove the cycle, good in PMDD, I have to say, and PMS/perimenopause transition times, Dienogest or drospirenone with add-on estrogen if needed is really helpful. Obviously, we know about the Mirena, but I think that drospirenone is like an oral Mirena with a better chance of getting no bleeding if you don't get chaotic bleeding initially. So that is an excellent tool to use. And don't forget about offering endometrial ablation and referring for it. The hospital's actually doing a reasonable number of them, but certainly the private gynaes are quick to do an endometrial ablation. It makes a massive difference. Just ask them to put a Mirena in if they're thinking they might be having menopausal hormone therapy with it. But ask about periods. A lot of women don't sort of verbalize that. Body aches are incredibly common. The treatment for it is difficult if it's not a hormonal base. Testosterone and estrogen do the best with these. There's some work out to show that amitriptyline, which is commonly used for this sort of pain and ache, is actually not terribly effective, and the side effect burden is quite high. You can still use antidepressants, pregabalin, and other medications, but their side effect burdens are a bit problematic, particularly because of weight gain and sexual dysfunction, which are obviously a problem at this time anyway. So really important to ask about and assist. We know that if women wake with pain in the night and you give paracetamol, it actually does help them get back to sleep again. Regular activity is really important. Motivation can be low, so encouraging that, something that's accessible, is really wonderful. And the Mediterranean diet becomes important because of its anti-inflammatory effects. Having excess adipose tissue is problematic when it comes to body aches because of the type of estrogen that it produces. It produces estrogen, which is more inflammatory and actually promotes more of the joint inflammation and pain. But obviously weight loss is a topic in itself and isn't the easiest thing to prescribe. And obviously managing stress and workload for well-being, as we've just reviewed. Palpitations are a really common symptom. I'm going to talk about them in the vasomotor symptoms, and gastrointestinal symptoms, which we've touched on briefly. It's more important just to, when you start hearing these things in the conversation, you hear tummy upset, bloating, irritable bowel so often, but when you start hearing it at this time, sometimes it's meaning more, and it's often a new symptom that people experience. And they're managed in exactly the same way as you would manage those symptoms outside the perimenopausal symptom phase. Hilary just spoke very eloquently about insomnia, and we've had some lectures on managing sleep problems. The insomnia that happens in perimenopause is unusual in that women will wake in the middle of the night and be wide awake. They're up like meerkats, ironing, doing chores, cleaning. They have to get up and go and read a book. They just cannot get to sleep. And it's a bit different to the usual insomnia caused by anxiety, stress, or long-term sleep disruptions. Often it's a change in it. Again, it's about the difference in what's happening. Women will complain of sleeping more lightly, more easily interrupted. Partner snoring can be more of a problem. They're also irritable about that. You can get increased night rumination, anxiousness, and of course you could be flushing and having sweats and adrenaline drive at night, which affects sleep. Management of this is using the normal insomnia management treatments that we would normally use if you're not going to use menopause hormone therapy. Even with menopause hormone therapy, you can't always eliminate that morning waking. It can be a troublesome symptom. But restoring sleep, for example, by addressing flushing and sweats, increased exercise, lifestyle changes, good sleep hygiene, melatonin, suvorexant. Very occasionally, I'll use a short-acting hypnotic at the 1 a.m. waking if it's really difficult for work. If you address sleep, you improve quality of life massively. So weight gain is one of the big things that women complain about. And I'm sure that most GPs sort of shrink inside every time someone says weight gain, because it's such a complex issue to resolve. There is a huge weight gain at midlife, but it is not just because of perimenopausal times. This is an age-related change. It happens almost universally. Nearly everybody experiences weight gain at this time. There was so some of the studies that I was looking at, it's about 1 kilo a year for a decade. There was a good Swiss study that was done. These are the Australian statistics, actually shows about a 5 kilo weight gain over that decade. But certainly there is significant weight gain over particularly a person's 40s. And it can be exacerbated by perimenopause and menopausal change because the distribution of fat obviously changes. Clothes don't fit the same way. You can imagine if someone's got a professional wardrobe, that's thousands of dollars to have to change that. Their body moves differently. Their fat increases, their muscle mass is decreasing. And overall, their BMI is not going in the right direction. It's also incredibly difficult to address that. There are changes in the metabolism of glucose that are happening at this time. Don't use as much glucose, particularly in the brain. It uses alternate sources that are less efficient. Most women will say they can't eat carbs anymore. Absolutely. I think that Kate will probably talk a little bit about those. But although this is happening at the same time as these other hormone-influenced changes, it is happening in men as well as women, and it is happening regardless of menopausal status. So weight gain in the midlife is happening regardless of whether you are pre-menopausal, menopausal, post-menopausal. And this is an Australian data graph just showing that the proportion of people that are moving into the substantially increased risk of adverse health outcomes because of their weight, and it's happening to men and to women. So we talked a little bit about the complexities that are happening at this time, and women will come and say, I'm doing the same things, I'm eating the same, I'm exercising the same, and I'm putting on weight. But what they're not seeing is what's happening in their bodies and that their body's changing, and they can't control that. It's very frustrating and it's distressing. I feel like I'm doing the right things, but I'm not getting the right result. And that actually creates a fair amount of distress because that person can't do anything different to have a different outcome. So explaining what is happening and resetting expectations is really, really helpful. I only aim for weight stability when I'm acutely treating perimenopausal and menopausal symptoms because their mental health and well-being needs to improve before we can really get that addressed. This time of life often brings up past stressors, trauma, and non-hungry reasons for eating. So if eating and food is a non-hungry tool or a therapy tool for a patient, it may be exacerbated. Eating disorders get exacerbated at midlife as well because of the emotional distress that it brings. So resetting expectations is really helpful and getting to people to stop weighing themselves frequently. Explaining that there is a 10 to 20% metabolic rate reduction between 30s and 40s. You're not using the calories that you used before. You certainly aren't using carbs the way you were before because simple sugars are not processed. Glucose isn't being used as an energy source as much anymore. There is a new body shape and that is difficult to challenge. So helping women adjust to that. And there's the concept of calories controls versus exercise as weight loss. We want exercise, no doubt, about health. It's absolutely essential for good health in our later years. Doesn't do much for weight loss anymore. We do need to moderate calories, but we want good quality foods. The Mediterranean diet has got the best evidence for health outcomes, and actually by World Health Organization review has been determined to actually improve longevity as opposed to all the supplements that are out there that they examined, which showed that there was no difference. Menopause hormone therapy, if you chose to use it, is actually weight neutral. Some people will improve, some people won't. So we don't use that for weight management at all anyway. And medical management can have a part to play, but I do get concerned that when that management is stopped, that the weight returns because the underlying reasons haven't been addressed. But I do use a fair amount of Duramine because of the low energy that is happening at this time. If you use Duramine, you can actually get a little bit of a stimulant effect, an appetite suppressant effect, and a woman can feel like she's got a little bit more control over what is happening to her until she's in a mental state to really take it on in a more holistic way. And there are some exciting developments around gut microbiome. So there's a company called BioAli, and there might be others who offer supplement sachets to modify gut microbiomes in order to swing the metabolism in the direction that you want to supplement other activities. So it's a pretty exciting time in terms of the nutrition world. So on that note, I think Kate is going to give us some insights.
Good evening, everyone. Thanks, Virginia. I'm so enjoying listening to everybody and hope that I can do the rest of the evening justice with my presentation as well. So yeah, we're looking at nutrition in menopause and specifically touching on weight gain and the Mediterranean diet and looking at how nutrition can help with maximizing health for women at this time in their lives. So a little bit about me, just briefly, and the introduction was very lovely. So I'm a registered nutritionist with the Nutrition Society of Australia. Essentially, that just means that I'm a university qualified nutritionist rather than an Instagram qualified one, which unfortunately is important to point out these days. So let's get stuck in. I actually love how my presentation is fitting so nicely into my panel. I'm not going to stay on this slide for very long, but I just wanted to start with it because I think it's important to note that in the broader context, particularly from a nutrition perspective, of what women are going through at this time of their life, because there's lots of interrelated factors, as we've discussed already, that really sort of comes together that impact their health. And so obviously some of these changes are being driven by hormonal changes. So we do see an increased risk of cardiovascular disease, an increase in insulin resistance, impaired insulin secretion, changes in fat storing patterns. But also happening at the same time is we've got the changes that are happening with our body at aging, so just general muscle losses, decreased gastric acid production, and increased risk of those chronic diseases and osteoporosis. We then have all those major life stresses. We know that stress plays a huge role in people's ability to choose food and affects the way that they eat and choose food. We have changes in lifestyle. So population research shows us that during this phase of life, there's less regular family meal times, more dining out, less structure around meals, perhaps more distracted eating, so eating in front of the TV or eating while driving. And I guess all of this is then happening in a broader context of quite a weight-obsessed society that really values young, thin women. And so we then have internal and external weight stigma, high pressure to be in a body that now feels that's thin, and now even more so, weight feels like a harder thing to control for people. And this then obviously, as we've heard, affects their body image and subsequently their psychological health. So when it comes to menopause, I think it's really important that women understand that nutrition can't actually stop the hormone-driven changes in the body. And the fact that I even have to say that is testament to all the misinformation online, because despite this, they are confronted with lots of information online about the balancing their hormones, and they can do all these things to change their hormones with food. And so I think what's important to note that when you're talking to patients about nutrition in the context of menopause is that these changes in hormone levels does increase risk of chronic disease. So in particular, we see an increased risk of developing type 2 diabetes, an increased risk of cardiovascular disease, osteoporosis, mental health. And so nutrition can absolutely play a very key role in decreasing your risk of developing those things. And that's really where nutrition shines at this point in life. And I've just given a really high level overview of I guess, the key dietary strategies that we would be looking at depending on the health goal of the individual. So from, say, for example, for type 2 diabetes, we'd be looking at carbohydrate management. What's carbohydrate looking like? We certainly don't have to cut them out. We're not saying no carbohydrate, but perhaps a lower carbohydrate eating pattern is something that might be helpful here. And it's helping the individual really achieve that in a realistic way. So there's obviously very good evidence of nutrition and its role with decreasing risk and managing these chronic diseases. In terms of more like the menopause symptoms, the evidence is less concrete, as we've heard. So there's no sort of concrete evidence that diet or specific foods can stop any of your menopause symptoms. There's weak and maybe sort of like indicative evidence that things like diet quality and phytoestrogens may help with sleep or may help with hot flushes. And I think what's important to remember is, particularly when I say diet quality on this slide, is I'm really looking at, does the individual have a wide range of minimally processed foods regularly included in their diet that both nourishes and satisfies them, that then leads to that overall feeling of well-being, which then has a flow-on effect to less stress and better sleep and the subsequent improvements that come along with that. So the Mediterranean diet, as we've heard, is certainly has the strongest evidence base for decreasing risk of chronic diseases and being protective against those chronic diseases. So specifically type 2 diabetes, cardiovascular disease, and some cancers. And the way that it does that is through a variety of methods, from the gut microbiome to reducing inflammation to managing metabolic syndrome and insulin resistance. And there's a number of mechanisms that we've now sort of have a really good evidence base on why this diet works the way that it does. And so just a little refresher, one of the frustrating things about science is that you can read a paper on the Mediterranean diet and it won't actually tell you what it is that the participants were eating. So this is a very high level overview of the Mediterranean diet. So it is a diet that is rich in plant-based foods. And we're looking for minimally processed, the less done to the food between the farmer and you, the better. So lots of fruits and vegetables, But it doesn't stop there. We then move into legumes and grains, so specifically whole grains, so minimally processed foods, nuts and seeds, and then that forms the sort of foundational part of the diet. And then we want to add animal products if the individual chooses to eat them on top of that, offering complementary nutrition like protein, omega-3s, B vitamins, etc. So in this instance, with the Mediterranean diet, we'd be focusing on seafood, poultry, eggs and dairy. Red meat, it can be included, and certainly if you have patients who are still menstruating, red meat once or twice a week as part of this good diet quality might be important for managing their iron levels if they choose to do that. But we'd have them focusing on reducing red meat. They don't have to fully cut it out, and focusing on those other animal products. And of course, I would be very remiss if I didn't say that the Mediterranean diet shining hero is olive oil. And in fact, very, very old, traditional Mediterranean diets recommend 6 tablespoons of olive oil a day for people, which can be pretty overwhelming. So the inclusion of extra virgin olive oil as part of the diet in cooking, salad dressings, it forms the basis they're getting those healthy fats in. And so, like I said, the mechanism here is, this diet has been shown to maximize gut microbiome diversity, reduce inflammation. We're providing adequate fiber that flows on to cholesterol management and blood. We've got nutrients for blood pressure management and so on. All right, so let's talk about weight gain, because as we've discussed, this is a huge thing. Certainly in my experience in working one-on-one with people, that this is the biggest concern for menopausal women, in addition to the symptoms they're experiencing. And as such, they're victims of huge amounts of marketing campaigns selling them products and programs and supplements and protocols. And I hate that term I see in advertising called the meno belly, how much shame and stigma is attached with this changing shape of women that they then play on to advertise to us. So essentially, I just want to share just a couple of key important points around weight gain and menopause. So the data that Virginia shared was really excellent. I've seen so much variation in data on weight gain, but I think what's important to note is that experience is variable. Some women will put on a little bit of weight, some will put on no weight, and some will put on large amounts of weight. But certainly overall, independent of menopause, we put on weight gradually as we age, as a general rule that happens. Another study showed that 83% of postmenopausal women report low body image. So that's a pretty high proportion of women who are really struggling from that perspective. Body image worsens with the severity of symptoms. So that same study found a positive association between severity of menopause symptoms and worsening body image. And then we have that weight stigma and weight bias, dominates our cultural view of bodies. And there's actually evidence that shows that this stigma and shame that they feel about their bodies actually stops women from accessing healthcare that they need. They stay away from the doctor, they stay away from going to the hospital, they stay away from getting their medications checked if they have diabetes, things that should be regularly monitored because they feel shame about their body. The other stat that I actually found quite surprising, and then on reflection of my career, I thought, well, that actually makes sense. But postmenopausal women are the second most at-risk population for an eating disorder. So that first population being, young adolescent people and girls. But yeah, so this age group is we're really working with women who are really struggling at various levels. So why does weight gain happen? I think, Virginia's touched on this so nicely, so I won't spend too much time. But we've got a perfect storm, really, for weight gain at this time of life. We've got these hormonal changes that are changing how our appetite functions, an increase in insulin resistance. We then have this body shape change, a change in our routine and lifestyle, less regular food habits, etc. And then, of course, the changes that come along with aging. So my professional opinion is that there is a wrong and right way to manage menopause, particularly from a weight perspective. And this has come from, working with women for over 15 years one-on-one, and I spent a good deal of my career in weight loss, is that actually taking a health first approach with your patients rather than a weight first approach is more beneficial to their long-term health. And it just takes that pressure and stress off them. Doesn't mean that they won't lose weight. It doesn't mean that their weight's not important, but what we're doing is we're focusing them on what they can control, which is their daily behaviors. And it puts them back into that place where they can sort of, build that self-efficacy, like Hilary said, in these various areas of their lives where they feel like, okay, I can make a difference here. So things like encourage a focus on diet quality, movement that your patients enjoy, encouraging them to seek help for body image and help for their mental health, encouraging them to build skills with food. I've met some women who are high-level professional women in their jobs and they can't chop vegetables or they don't know how to cook fish. And these basic skills impair a person's ability to put nutrition advice into practice in their lives. And they then feel a lot of shame and stigma about the fact that they don't have those skills. So being really empathetic and kind and encouraging them to seek help is so important. I would strongly advise against rapid weight loss. This can actually impair their muscle mass and actually cause more muscle mass losses, which just makes everything worse. It exacerbates bone mass losses, which then later on in life increases their risk of falls and poor health. I'd also discourage them trying restrictive diets like fasting or keto, as this actually increases their risk of disordered eating and places them under more stress. There is really good evidence, and I can share a paper with anyone who wants to read it, that pressure to lose weight from health professionals can cause a high amount of psychological distress. So just being mindful of that conversation. A lot of women have been trying to lose weight their whole lives. And what can be really hard is they then see a health professional that's like, well, part of your problem is that you need to lose weight. And they walk out and they think, well, I've tried and I've failed. So that leaves them in a really disheartened point and really disempowered. In my personal opinion, which I would say is a very evidence-based one, is that weight loss at any cost does not actually improve health outcomes at all and may in fact impair health. So just to kind of touch on specific nutrition interventions that we would be looking at when we're working with clients, which would be putting those Mediterranean diet principles into practice in our clients' lives in a way that's easy for them to do. And there's very good evidence that shows that the best diet for the individual is the one that they can consistently stick to. And so what we're doing through nutritional counselling is helping them make these sustainable changes. I'd also recommend just regularly screening for micronutrient deficiencies. These are a couple of the key ones to just note down that are of importance at this time of life. So where to start when you're looking to focus on health and not weight? I've got 5 reasons why you should do that, just that I'll just briefly go through. So, people have often, like I said, spend a lifetime trying to lose weight. So we want to try and empower them to focus on their health if weight has been hard for them. Science is actually telling us that it's our health behaviors, like what are we doing every day, that are better predictors of long-term health. And the other research shows us that 80% or more people who lose weight regain it. So prescribing weight loss is like prescribing a medication with a less than 20% success rate. So we are better off on focusing on things that can help decrease their risk factors. You can decrease someone's risk factors of type 2 diabetes with good nutritional strategies, even if their weight doesn't change throughout that process. And I think that that's really important to know. Some people do lose weight as a side effect, other people don't, but it doesn't mean that their health outcomes haven't changed. So I'd strongly recommend referring to an accredited practicing dietitian for that. So this is the one on my team over at Ayla Health, which is my new business, but I also have a whole team of dietitians over at the Healthy Eating Clinic. We take Medicare referrals and their first session with us is free. And super quick plug, because this is very exciting. This is my app that's due out on the market very, very soon, hopefully October. So stay tuned for that. I plan to revolutionize the industry in terms of how we help people change their eating habits long term without stress. So thank you very much.
Virginia, have you added
Yeah,
in?
shall I keep
Yep.
going?
Yep.
Oh, sorry, I had my speaker on. Okay.
Yeah, that's all right.
Thank you so much for that. I did want to actually say about the sustainable change. That is the difference, isn't it? When you hit midlife, you can't go back to the patterns of cutting back your naughty foods and exercising more and dropping a few kilos. It doesn't work anymore. And the changes are sustainable, long-term and small incremental changes towards a target that will take years now instead of just a few months. Okay, so I'll share my screen. And I know we're short on time, so I want to get through genitourinary symptoms really quickly. Sexual dysfunction is really big around midlife, and I was pleased to see the comment that Hilary made about, in actual fact, it's probably not as serious as I think. It feels serious. I see a lot of people who are experiencing low libido, and they are upset about this because their partner then feels the impact of that. They don't want that to happen, but also how do they motivate themselves to have sex when they don't feel like it? It can become uncomfortable. The changes that happen in the vagina are significant. About 50% of women should be treated for genitourinary syndrome of the menopause, but about a quarter are. And one of the significant changes is that the epithelial lining really thins, and those cells that usually slough, and they're full of like glucose essentially for the lactobacilli to consume, decrease. And then when you get fewer lactobacilli, you get a more alkaline pH, the organisms in the vagina change. And so then you get altered discharge, you get reduced perfusion of the vaginal tissues, so you can get itch, you can get burning sensations, you get reduced blood flow to the clitoris, so you get altered sensation, more difficulty climaxing. You might get the alternative, which is intense pain of the clitoral area. And you can get changes to discharge and the skin itself. And all of this, you actually also get thinning of the rugae. So the actual vaginal tissues, instead of being folded, become flatter and stretch as well, and you can tear more. So you can ask questions around this. Women are a little bit reticent to talk about it, but dryness of the vagina is actually a really good topic of conversation now. It's more socially acceptable to talk about that. So that would be a lead-in question. Or certainly if are they feeling like they like having sex? Do they want to? Is it sore? Are they lubricating themselves well? Are they sore after intercourse? And would they like to treat that? If you're examining a patient, I'll just go back. What you're looking for, as you can see, dryness of the labia. You can see pale color or bright red colors. It tends to be a bit drier. The skin doesn't stretch as well. And you might see a patulous urethra. Generally means that there's changes there, previously called atrophic changes, now genitourinary syndrome of the menopause. And that is to represent the fact that the lower urinary tract is also involved in this. You get bladder irritability. So if you ask somebody who may be in a perimenopausal state, do they have urgency to get to the toilet? Do they potentially leak on the way to the toilet? Is that new? And many, many women will say yes. They go to the toilet all the time. They feel the sense of urgency different to what they used to. And those women would benefit from treatment of their symptoms. Because of the inflammatory the anti-inflammatory effect of estrogen, when you remove that, you can get some more autoimmune conditions coming through, and vulval conditions are no different. So just being aware, I know we don't do cervical samples so much anymore, that they're self-testing now, but looking at vulval skin, don't bypass it, do look. And if someone complains of itchy vulva, particularly if they're midlife or onwards, please look, because it's not thrush. It'll usually be something else. And you'll need to take swabs to look at imbalances as well. If you're not going for menopause, vaginal estrogen, which actually shouldn't be considered as hormone therapy because it's so safe, it's over the counter in the UK, do think about using it. Vaginal estrogen, or DHEA, actually replaces vaginal microbiome, and none of the other treatments do. So vaginal moisturizers do improve sexual function, and they do improve vaginal comfort, but they don't restore vaginal microbiome, and so it's not the whole solution for people. There are some suggestions there for brand. I'd also say that oil-based lubricants versus water-based are much more helpful in this time because the lubrication effect is better, but they're available online because they damage condoms, and that's a very good idea, but it makes it more difficult for people to access them. And the other comment about vaginal moisturizers is if it has a natural base like coconut oil, it's actually associated with microbiome changes in the vagina that aren't advantageous. So it actually is better to stay with the ones that are not natural. If you are thinking about prescribing progesterone, which has just come out, that's intrarosa, DHEA. It's actually better than vaginal estrogen for lower urinary tract irritability, but it is every night instead of twice a week. And if you have best practice, you do have to prescribe it by brand still. They haven't entered it in as chemical name. Talked a little bit about discharge changes. I see a lot, and it can be really tricky to manage because you get a reduction in good lactobacilli and you get an imbalance with other often aerobic bacteria. So you could do a high vaginal swab and get a culture back, and it looks normal. But it's really important to have a look at the epithelial cells that are in it. If there's not very many, it may be because there weren't many to start with. There might be a lot because they're sloughing. And you can have, if you have a reasonably heavy load of aerobic bacteria, it's very possible she's got aerobic vaginitis, which can actually be, can escalate into being an inflammatory desquamative condition, which requires antibiotic and steroid intravaginal compounded prescription medications. Altered vaginal smell is actually a relatively common effect too, and vaginal estrogen will usually resolve that. We talked a bit about sexual dysfunction, and I won't go through that. Apart to say that some supplemental testosterone should be considered, and there are a lot of myths around that. So vasomotor symptoms are actually deliberately left till last because I think we hear a lot about them. About 80% of women will experience them, 20% won't experience many at all. We've talked about changes to the thermoneutral zone. Within that, you've got a narrowed thermoneutral zone. That means you get hot flushes, you get cold flushes. And then within it on the cellular level, you've got a balance between estrogen and neurokinase B. And when there's no estrogen, the neurokinase B flicks the receptor and you end up with hot flushes. Of course, adrenaline can exacerbate hot flushes, and so can anxiety and alcohol. But this is the final switch. And so fezolinetant is a medication that is a receptor antagonist, so that if you've got no estrogen, you can essentially say you don't have any neurokinase B either, because it's blocking the receptor, and it evens you out and reduces flushing and sweats. Now, the reduction in sweats and flushes with estrogen is about 75%, and you can achieve 65% with this non-hormonal medication. So it's a real game changer when that is the primary symptom. And if we go back to women who are having trouble sleeping, if they are having sweats and flushes, if you improve those, you may sufficiently improve their symptoms so that they don't need any other treatment, that they can then cope better with their other symptoms using lifestyle strategies. Side effects are really low, but just a reminder that you need to check the liver function tests at 1, 3, and 6 months, and 6 months ongoing, because a small number of people get liver enzyme abnormalities from this, but otherwise it's very well tolerated. The other caveat with it is that unfortunately they haven't done a trial specifically in women post breast cancer. So although it would appear to be safe in breast cancer, there's not actually a study to say that it is. I certainly have used it very successfully and got some really positive results with fezolinetant. Again, if you're on best practice, you have to prescribe it by brand name because it's not turning up under its compounded chemical name, so it's Veoza. If you are thinking about using other medications for hot flushes and sweats, the evidence base is good for antidepressants. So you can get sort of a 50 to 55% reduction in severity of symptoms. Oxybutynin can be used, but the side effects can be problematic and they can actually cause flushes. Gabapentin, problematic with side effects, but again has demonstrated some benefit. In clonidine, which many of you who've used that for other reasons find sometimes that's a bit tricky to use. But there is also an evidence base for cognitive behavioral therapy. Hilary's been through the benefits of that, and some other treatments such as for severe refractive cases, stellate ganglion blockade, which would need to be done in Sydney. As far as I'm aware, I haven't had anyone in Canberra actually access that yet. Palpitations are part of the vasomotor symptoms because they trigger adrenaline drive and then are associated with the same processes. Women will commonly complain about palpitations, which from a GP setting can be quite irritating because that's a consult in its own. And I have decided that I'll flick off an ECG and a Holter monitor and say, let's just treat your perimenopausal symptoms. And if they're still there, we'll deal with it as an issue on its own, and they go away invariably with treatment. So unless there's any red flags around them, I actually defer serious investigation. Migraines are also a really big perimenopausal symptom because, of course, it's fluctuations in hormones that create hormone-sensitive migraine. We see it in adolescence and early 20s. We see it in perimenopause. And it's actually the non-aura form of migraine that increases at this time, although I see an awful lot of aura and ophthalmic migraine at this time as well. So stabilizing estrogen and cycles is really helpful. So even if you didn't want to use hormone replacement therapy, you could be using a product like desogestrel to take out ovulation and even out the cycle, just to remove some of the fluctuations that happen. Migraine should continue to be treated as you would normally with first and second line treatment and maybe even prevention. But people who are using patch menopause hormone therapy usually do well because it's a much more stable estrogen status. But ask about it. It does change a lot, and it can have an incredibly big impact on work and well-being. It's also an opportunity to talk about prevention when you look at VTE risks and lifestyle. Quick comment about aesthetics and menopause. We talked before about social stigma. Midlife for women who are working is a really stressful time if they're affected by these symptoms. And often they'll watch their male peers be promoted above them. There's ageism, there's sexism, and they're coinciding at the same time that a person is losing their confidence because their performance is being, from their perspective, impaired. So it's a really vulnerable time. And then when a person's face changes, because of course you lose 30% of your collagen around the time of menopause, suddenly you see signs of aging that remind women of their mother, of their grandmother, and they're feeling even more vulnerable to this sort of unprecedented and uncontrolled train that they're on, that they sort of can't step off. And so helping women feel a little sense of control of who they are and how they look can be really valuable. Hair loss is a really common complaint. I think GPs sometimes get anxious about managing hair loss. It's an incredibly common experience. 65 to 85% of women will experience significant hair thinning by the time they're in their later years. There's a good trial using a combination of minoxidil and spironolactone, so 25 milligrams of spironolactone and 0.5 milligrams of oral minoxidil compounded, has really, really good results. Or you could use spironolactone on its own with topical minoxidil. Just know that there are treatments for hair loss. It is complicated. It's a whole talk on its own, but don't be afraid of it. There are treatments out there that have got an evidence base now. Rosacea, acne, skin problems, backne. A lot of people get acne on their back and be problematic. And so I refer people on for Accutane sometimes to help manage all these problems. But there's a lot of good news. So one of the things around pain is that there's usually something good that comes after it. So menopause is a transition, and being really positive about this transition can seem hard because everyone's very fearful about what they're going to experience. But once this tumultuous time has settled, women actually become happier than ever before in their life. They're generally free of the expectations of caring for others. They are able to be self-determinant. They're much better at putting boundaries on how they spend their time and their energy. They're much better at looking after what is important to them and focusing on how they want to live their future years. And so perimenopause is an absolutely amazing time where you've accumulated enough evidence of risk factors to see them. And we've got enough information to know what that prediction looks like in the future, but we've got enough time to change that trajectory. So if we embrace this as a real health review time, we know how to make people, we know what we're aiming for, making them better. It is regular exercise, moving as much as possible, It's about having healthy relationships, working as long as people feel happy to do so, and a Mediterranean diet, or at least a diet along those themes. We know that those things predict better outcomes long term, and we've got an opportunity to influence that transition. So part of a perimenopausal assessment is like a midlife assessment, and you do look at insulin resistant patterns, bone density. I often do bone densities and find out a person's osteopenic, and that really motivates them to start weight resistance exercise, which can make a difference. Maybe reintroduce some calcium into their diet, make sure their vitamin D is up to speed. Alcohol reduction, worse for perimenopausal symptoms. We don't want much drinking going on, and we're thinking about neurocognitive changes as well with that. And this is an excellent time also to address past dependence issues, because actually at midlife, sometimes people resume risky behaviors or coping strategies like using substances that they haven't needed to use for years. So definitely ask about those things as well. There's loads of options for exercises. You can just Google menopause exercise, Canberra, and a whole bunch of options do come up. But the most useful one I found is a GP care plan, a single episode with an exercise physiologist, and a set of home exercises that use a bit of weights. The rest of it women will engage with as they like. But if you've got a little bit of weight work and movement happening at home, and then they're engaging in other activities, either in a group or in a gym or walking, then they're doing more than they were before. And there's a couple of references that are actually the same as the ones that Hilary and Kate mentioned. The Balanced Menopause app, of course, which is incredibly useful and has links to very good articles. And I recognise that the Heart Research Institute, Kate, uses your work for their dietary advice. I tend to use the Australasian Menopause Society has an excellent 5-minute video on the safety of menopause hormone therapy, but the British Menopause Society tends to be a little bit more user-friendly. Jean Hales talks a lot about supplements if people are interested in using non-hormonal methods for supplements. And if any of the people who are watching are interested in working in this space, if they could get in touch, because we need more doctors doing this work. It's very, very rewarding work. So thanks very much.
Thank you very much, all the speakers. I found that a very uplifting and optimistic presentation. All of you had really good advice, and it was practical advice that made sense. And I think the best advice kind of is often common sense, and there was also added in with evidence-based science. So thank you all very much for speaking. We've got a couple of questions. We've only got a few minutes, but I will see if we can zoom through the questions. So one person was saying, in what way is menopause a qualification for a GP management plan? Well, I guess it isn't, but many people have other chronic comorbidities, so that would be, you'd have to tie it into that. Do you have any comments on that, Virginia or
Look,
Hilary or Kate?
I think it needs it because it's usually multifactorial. So you've got psychological symptoms. They're usually overweight, and they usually have some sort of pain of some sort. So you can certainly stretch it. In fact, I presented at the parliamentary inquiry on Monday of last week, and they're talking about using a specific care plan for menopause. So yes, I do think you could use a GP care plan.
Oh, that's very positive. Another question is, any thoughts on mirtazapine for poor sleep with concurrent anxiety, depression?
Weight gain, big problem.
Yeah.
At a time when women are so sensitive. So yeah, they'll try it, but they usually don't stay on it.
I very much appreciated Kate's kind of advice on diet and not seeing food as the enemy, but going for whole foods and real foods. That was very valuable. I had a question, and I was just going to say, how do you help? So a lot of young women are now being diagnosed with breast cancer, so they're often going through menopause early, or they've recovered and they're 50 and they're going through menopause naturally. Is there anything that all of you could help them out with, non-hormonal treatments, lifestyle advice?
Hilary, you start with that one.
Yeah, I think this is sort of where I got my start in the world of menopause, was working with these types of clients. So I think often when women are entering a surgical or a medical menopause, that the symptoms come much harder and faster. There's not that decrease over time that other women would experience. So there often is just a lot of, I guess, education, psychoeducation about those effects. And then it's probably similar to what we would do with anybody experiencing menopause, but again, thinking about that broader context of their experience as a younger person, and there might be some increased losses that an older woman might be experiencing. So it's really, I guess, meeting the needs that are individualized for that person. Going through menopause as a young person, and I'm talking young, probably under 45, there's a lot more problems with, I guess, sense of identity or sense of feeling like a woman and all those sorts of things. So I guess the focus tends to be a bit more on some of that kind of work. But as far as the non-hormonal management, I guess then we're looking at potentially more along the lines of antidepressants or some of those other medications that Virginia was talking about. I think recently I had heard that in the UK, at least there are some doctors there who are still prescribing, or now again prescribing MHT, even if you've gone through breast cancer, depending on how bad those vasomotor symptoms are and how much it's impacting on life, and clients then, or patients, being able to weigh up the balance of sort of risk to them and versus their quality of life. So it's perhaps not quite a straightforward answer.
Thanks. Virginia, have you got any comments?
Australia is really conservative around using hormones, and we're still struggling to get vaginal estrogen for women who are post-breast cancer, and really they should be able to access that. Some of the oncologists and breast surgeons are okay, and some of them aren't. So unfortunately, we're still in a position where we need to ask permission from them to do that. Yes, in the UK, they're having more complex discussions around consent, but I think that that's because they've got a much more sophisticated structure around who makes decisions in health, whereas Australia doesn't really have that support yet. And there are certainly women, even with estrogen receptor positive breast cancers, who are having HRT therapy in the UK. Certainly, they're much more open to estrogen receptor negative breast cancer having a menopause hormone therapy there. So they're definitely at the forefront.
Yep.
I think the shift in Australia is really letting the woman make the decision. And where does that leave a person? I think that GPs in Australia would feel a little bit too vulnerable.
Right. Yep. I had one more question, and I thought it tied into that. So a lot of people like to do things naturally. So black cohosh, red clover, hops. Are there conditions that GPs should be able to warn patients about, like kind of increased risk of breast cancer or untested, or endometriosis with some of these natural therapies?
I guess if you're looking at phytoestrogens and isoflavones, you might think that if they've had breast cancer, they really shouldn't be having those. And probably that is this current status quo. With endometriosis, I wouldn't. The doses are so low. The benefit for phytoestrogens for flushes is actually better if you've had a high soy diet as an adolescent. So the benefits, they're definitely there and minor, but not an overriding concern for endometriosis, but are a little bit of a caution if a person has had breast cancer just because of their weak effect.
Right. Yep. We'd better wrap it up there. So we've hit 8:30, but thank you so much, all of you, to Kate, to Hilary, and to Virginia, for such fantastic and engaging presentations. I'm sure all the audience would agree with me. Just on the kind of admin bureaucracy side of things, we'll be sending out an evaluation survey, so please complete that and send that back to us. And if you've attended for most of the webinar, we'll also send you out a certificate of attendance. So I guess anyone who's hearing this message has stayed for most of the webinar. So thank you again to all our speakers. It was really very interesting and a positive presentation on menopause, which is really nice. And good night. Thanks.